Good day, and welcome to another webinar from the Global Summit Institute. My name is Dr. Sonia Aykroyd. I am a speaker, CEO of the American Academy of Orofacial Harmony, and I've been a dentist for 35 years. I'm proud today to host and welcome one of our top 100 doctors, Dr. Jerry Hu, to talk about a subject close to my heart: pediatric airway and treatment options. First, I'd like to remind everyone that at the end of the session, you have a link down that you can click and register for CE credits. And also at the end of the session, there will be a time for some questions and answers. Now, I would like to introduce and welcome Dr. Jerry Hu. Dr. Jerry Hu is one of our top 100 doctors in dentistry. He's a dental speaker in sleep medicine, cosmetic, and implant dentistry. He has published in numerous peer-reviewed articles in peer-reviewed journals. He serves in various dental boards, including the Sleep and Breathing Academy, American Sleep and Breathing Academy, and the Academy of Clinical Sleep Disorder Disciplines. He's also an instructor for several dental organizations. Dr. Hu won many cosmetic dentistry competitions, from being the only 3 times grand prize winner in nationwide Max Studio Model Search and IAPA's Aesthetic Eye. He developed 5 dental IP patents in dental sleep medicine and created a startup company in Melbourne, Australia, named O2NU. In 2020, he completed a mastership program with Facial Beauty Institute, with the Facial Beauty Institute, and became a master instructor in orthotropics while attaining a certification also in chirodontics. So without further ado, I would like to welcome Dr. Jerry. I'm very excited to hear what you have to say for us today. And you can now share your screen and
thank you so much. Can you all see the screen? Thank you so much,
Perfect.
Dr. Sonia.
Thank you.
Yes, and it's such a pleasure to be able to do this because, like Dr. Sonia, this is what I'm most passionate about. Actually, even being more specific, the pediatric airway is even more touching, because when we as parents or people in the world look at how we see life, we would do anything for our kids, for our children. So this really is hopefully motivational and inspiring to dentists who have considered dental sleep medicine, as well as they themselves and their family, if they see their own kids. Because I actually started my journey by recognizing, identifying those issues that are red flags for airway development, craniofacial development problems. So let's get going and get started. Thank you for attending this webinar. And so let me go ahead and start right there. I did write these things kind of small font, so I'd rather people just kind of look, and listen to what I have to say. This is kind of an outline of what we're going to do today. We're going to talk about just some forms, like, for adults, there's Epworth, screening forms, and Stop Bang. There's forms as well for children, and some of them are very detailed. There are ones that, I'll share that you could go online and pay a small fee and get copies of. But it's very important because, when your patients come in, oftentimes their children are already displaying so many signs and symptoms that will affect their school performance, their growth development, and all of that. And, oftentimes in society, teachers and parents and, school administrators, they don't know what they don't know. And my fight really is to not have big pharma control everything, and have Ritalin, Adderall, and labels be the answer, but really to see how the child is growing, developing their airway, and have that be the main focus. So, let me go down here. I'm sorry. Okay. So there is the first screening form. It's actually from my alma mater, University of Michigan, and there's just 22 questions. It's a Chevron form. You can actually even download this. But I oftentimes just have little signs and things in my waiting room to where for adults, I would put like, systemic issues from heart, cardiovascular to Alzheimer's, dementia, and whatnot. For children, there could be things like, hey, is your child still wetting the bed? Is there nocturia? Are there those other things that, even though it may be embarrassing, maybe during the hygienist appointment, right? They're getting their dental cleaning done. Oftentimes, I find my dental hygienist is very, very close to the patient's family, and anytime there's any issues, or even they're not doing well at school, they can't join any sports, or they're very irritable, or their grades are failing, or those things kind of come up. And so these are very, very important tools and measurements to have available to ascertain and assess for your patients to fill out, as well as the SDIS. This is the one that if you go to her website, of course, this really looks into a lot of things, from behaviors to allergies, the classical things that you often may see. They can have a presentation of adenoid facies, or their mouth breathing, they have a forward head posture. Those are, screaming for help, help, help. And what's amazing is we as dentists, we can really, really affect the development in everything from school performance all the way to how the family, gets by day to day. Once one child has an issue, the whole family maybe not be sleeping well and whatnot. So those are things to very much consider, that we as dentists, yes, we can look beyond the teeth, and look at the entire performance of a child and how they're growing and developing. One thing I want to add, though, is maybe just a little aside right here for people to think about. There are so many things that in our culture that kind of, especially westernized, civilized, whatever it was, we tend to actually make it worse for airway. The number one first thing is, if you are a C-section baby, it's very, very important to know. Christian Guillemot over at Stanford University, I was very fortunate to meet with him. He's no longer with us, but he absolutely underscored that C-section babies should be inoculated with the vaginal fluid, because anything natural, like a natural childbirth, the baby, of course, coming out would have the bacteria. And that, we talk about probiotics, we talk about all these different things, and yogurt and things like that. It's important to have that inoculation so the flora could be proper for the child development. After that, of course, breastfeeding. Think about societies that, when you look at them across the board, the prevalence of sleep apnea or sleep breathing disorders is very low, or the incidence is low, is because in Western society, we tend to breastfeed sideways with the baby holding on the side. But if you look at, tribal or Aboriginal people, they often feed with the baby upright. And during that time, it's very important, because the only time as a human being where we can eat and breathe at the same time is when we're at a baby, a phase where the epiglottis hasn't done its full type thing. So that suckling, if you will, is very, very important. And after breastfeeding, it's also critical to remember and to know not to go to processed like Gerber baby foods or applesauce. They really need to eat and chew. It's that myofunctional therapy, that craniofacial signaling that's so important. So yeah, maybe it's a broccoli or a piece of carrot or whatever, but have them chewing and masticating is so important for that development. And then, of course, if we had preservatives or fast foods and things like that added to the equation, then again, certain things like allergies and body compensations will occur. So just keep that in mind as a general rule. And so this one's kind of like the stop bang that we have. It's fast. My hygienist loves to do the stop bang. Sometimes if she gets the neck measurement down, patient goes, well, why are you measuring my neck? And, she'll say, well, actually, Dr. Hu, he looks into people's airway, and there's people who have sleep bruxism and other things tied to the success of long-term, so just this conversation starter. And this is the Barris form is a very simple one for kids as well. That's kind of equivalent to kind of a stop bang questionnaire. So I also like to use equipment in my office, and really, I've been kind of dubbed over the years as an equipment junkie, and I don't mind to be considered or called an equipment junkie, because I want people to know that when you come to my office, I need to measure things. I want to validate, I want to remeasure, I want to make sure that my metrics are in place. there's often an old saying that says that, science is something that's repeatable. Something is something that you can study and have statistics with. If it's not, it's just an opinion. And I absolutely believe that. Whether any modality that I do, whether it's orthotropics or any type of just orthodontics in general and stuff like that, I can use things such as the Echovision. The Echovision is actually pharyngometry and rhinometry. And what you can do is use the sound waves, acoustic sound waves, so there's no radiation, and it's a reflection where when the sound waves bounces back, there's a sensor in the tube that gives an algorithm that provides a cross-sectional area of the airway. And it starts really at the very, very front of the mouth, in the incisor area. It goes to the velopharynx, where the epiglottis fold, that the angle is at. It goes down to the hypopharynx and the glottis aperture. And so that gives you really an idea of the cross-sectional space down the tube. And really, if you think about people who don't have sleep apnea versus people who do, it's really about two types of hoses, right? So if you think about a garden hose, the garden hose will always maintain its circular shape. And if everyone can have a garden hose, that's great because it will not collapse. In contrast, there is the fireman's hose. The fireman's hose, without pressure, without a precrit or flow or the Starling's resistor, it can be flattening. You can roll it up like on a fire truck, right? So to that degree, that's probably like the worst collapsibility. But with the Echovision and the pharyngometer, you can see how collapsible a patient's airway is and ascertain, what you need to do, whether it's a growth-guided appliance with orthotropics or you need to reposition the mandible. So having a tool like that, you can assess, and you can use, for example, the Mueller's collapse or the modified Mueller's collapse anyway to really, gain how effective your treatment modality is. And even as you're going through the process, you're going to be able to find, am I going the right way? Am I seeing that, there's a lot of neurology involved, there's loop gain, there's the vagal plexus, that long vagal cranial nerve, vagal plexus, right, for the pharyngeal muscles. All those things are interplaying with each other. So having equipment is very, very important. And again, cone beam. Cone beam is important, but I want to say that cone beam, of course, the position that you stay in, if you have your head kind of moved forward or back, that will affect how that slice will look, whether it's an axial or sagittal view. It is also one moment in time. When you look at cone beam, it's just static representation of that moment of the airway, or if you're using it for implant dentistry or whatever, it's not a dynamic, whereas prior, the Echovision, the pharyngometer is a dynamic movement. It's showing you live breathing in and out and movement. And so that is very, very key to understand. But having all that equipment and then matching it up, again, is even more effective. So this is one of the heroes, Karen Bonnick. She did a huge meta-analysis, right? Over 10,000 patients, actually 12,447 to be precise. But there is definitely correlation where when you're having an airway issue, it absolutely is tied to all the different childhood behavior issues. And every child, remember, can respond differently. Some get really, really hyperactive. Some kind of just become, lost at school, their days off. But if you think about it, if I were to choke your neck 200 times every night on a nightly basis, well, of course, your body's going to kind of go haywire and not respond really well at school. But if the teacher doesn't know that, then it really becomes a real kind of big shame for all of us, including society as a whole. Why? Because they'll think, well, maybe you're just, from parents that are hyperactive, or maybe it's just you have a ADHD or ADD or some kind of label, right? And that's really, really sad because it really stems from the child not being able to breathe at night. So when you breathe at night, when you get proper REM and you get all those things that are so essential, your immune system and growth and all of that, it's absolutely critical that we identify that and be able to help the child and the patient versus have them on drugs. So speaking of drugs, what are these things that often is used for children? And as a kid, you always hear about, oh, well, people use cocaine and people use all these different drugs, and one of them is speed. Like, oh my gosh, this person's on speed. And if you think about Ritalin, Adderall, they're just speed. And yeah, it's big pharma. They have a lot of power. They have a lot of lobbying. They have a lot of influence. To them, it's not about health. It's about their shareholders and how much money they can make, which is terribly sad. So, for myself, my own airway issues and my parents and my children, it's really, I think, a calling for me and hopefully to spread awareness and help other dentists be in the fight that, hey, look, we got to return back to basics. We got to return to how nature works, just like even that childbirth example, a natural childbirth versus a C-section. There are things that we need to respect that goes along the way to our entire development and how well we thrive, right? So that's very important to keep in mind. And so when you have a diagnosis, an airway, it has to be with a board certified CPMD in North America. Now, when I lectured in Hong Kong, in Kuala Lumpur, or when I had dentists that came from Copenhagen to Alaska, when I lectured for them, there was no such thing as a board certified CPMD or a specialist in those countries. So the dentists actually in those countries can diagnose. But we're here in North America, so Canada and the United States, you absolutely have to have that. So insurance and even your own liability insurance probably will not cover your liability if you don't have the diagnosis stem from a board certified CPMD. And that's okay, because board certified CPMD are growing in numbers in terms of allowing the dental sleep medicine aspect to be a very, very given option for the patients. Recently, as you guys can, all probably be aware of, Philips Respironics has the major recall on their Cpap machines. As well as the AHRQ 30-year retrospective study that came out that looked at CPAP over the long term, looked at its effectiveness, its mean disease alleviation, its apnea burden, apnea load. And honestly, we all know the answer. It is a joke, right? So even how Medicare defines CPAP usage as successful with 60 to 70% of the week at 4 to 5 nights. Imagine if you did a dental crown and you told the patient, oh, just use that crown for 70% of the time. Just to make sure you don't use the crown at night. The patient will go, what the heck? What kind of dentist are you, right? So, well, even in that situation, a crown is just a crown. I don't want to belittle it, but we're talking about sleep apnea, airway. We're talking about major health things, right? Tied to Alzheimer's, dementia, cardiovascular stroke, diabetes, so many things that are so serious. So absolutely, we need to really think about something that's long-term effective. And for children, orthodontics, orthotropics have been absolutely in the literature proven over and over again to be effective. And what I want to say here is that with a polysomnogram, sometimes dentists may have a little bit of trouble getting a child to get that sleep at the sleep center, because the requirement for a polysomnogram is 2 technicians, the certified sleep technicians have to be, so the profit for the sleep center may be less. So sometimes you have to kind of push a little bit. There is one home sleep test available for children, this is NOx 3. But the most important factor here is in kids, if they have an AHI, an apnea-hypopnea index of just 1, right, then they have sleep apnea. They're considered they have sleep apnea issues. And that's important. They are supposed to be sleeping very well. They're supposed to be thriving and growing. They're not supposed to have arousals. They're not supposed to have fragmented sleep. So that's something just to keep in mind. Even an AHI of 1, that child is considered to have sleep apnea. There are other things too that, different pulse oximetries and things like that you can do just to gauge, because honestly, in the hospital, if our oxygen desaturates to 90%, that means the emergency nurse is supposed to push a crash cart to you, right? And you'll find that these sleep tests and things like that will show people desaturate at night, especially during REM, to scary levels. And this is how celebrities from, Justice Scalia to Reggie White to Carrie Fisher, Princess Leia, all of them, their official toxicology is they died from sleep apnea. They didn't die peacefully in their sleep. They choked to death. And, that's very, very important to know. So having some, gauge of pulse oximetry is a good thing to have. Now, there are definitely a lot of different options. And, we want to think about the red flags that come in. And sometimes, even if you aren't a pediatric dentist, and mom and dad can talk about, hey, you know what? Like when I try to look back at the kid's throat, the tonsils are swollen, or you can look for tongue tie, all these other issues that are classic. Definitely trying to get a sleep test done is so essential, because that could mean the kid's whole grades to their ability to do sports, the whole 9 yards, right? So nocturnal bedwetting, tonsil grades. Now remember, sometimes tonsils can be tricky because the ENTs, they don't get reimbursed as well. It's really sad, but the way the world is, it's always kind of connected to the bottom line of of money, right? So, but if you record your kid at night gasping for air on your cell phone, for example, and you take it to ENT, there's no denying, yes, there's breathing issues, right? Of course, tongue tie, we need to talk about tongue release and myofunctional therapy. Zagi and Audrey Yoon over at Stanford has a lot of information and a lot of statistical evidence-based things that they go by in terms of how that's important for developing the three big things to keep in mind always for children. It's very simple. I call it the big three. One is nasal breathing. Nasal breathing is important because it allows for nitric oxide development. The other is tongue, the tongue posture, the tongue position to the end spot and the incisor papillae. And the third thing is lip seal. So the lip seal, the tongue, and nasal breathing, you establish that is the golden trifecta for myofunctional therapy. Other things that you see in kids, of course, the narrow palatal arches, mouth breathing, forward head posture, daytime sleepiness, behavioral issues, all of that, retrognathia, those are all things, mid-face deficiencies. You'll see that, you have to think about sometimes class 3, right? Class 3, you think of Jay Leno, and you think that his jaw is just, so protruded and so over. Actually, it's a mid-face deficiency. His maxilla did not grow to what it's supposed to, and there's going to be compensation, there's going to be airway issues associated with that. And this is Guillermo, I can never say his name right, but Guillermo over at Stanford. So this is kind of that perpetual, cycle. You have things that compensate. So for example, let's say not properly breastfed or poor nutrition or, other issues, and you start to breathe through the mouth and you have inflammation, not enough nitric oxide to fight that inflammation, and you have things like tonsils swell up, so you kind of go in this vicious cycle, then the body kind of compensates over and over again. So we as dentists, when we recognize this, we can totally intervene and make a huge difference in the outcome of that. And I want to say too that Zagi points out a very important thing. I always believe, of course, as dentists, as healthcare providers, evidence base is key. Now, I also don't think that it's right to dismiss an entire modality or an option just because of, well, there's not enough randomized control or there's not enough this and that. First of all, we need to realize that doing a real good double-blind randomized control study takes millions and millions of dollars, and it takes a lot of time. So it's not like you could just spit these out left and right, especially when you're talking about major modalities from orthotropics to Juan Moon's MSE to all that stuff, right? So there are a lot of meta-analysis and I would say case series feasibility studies. But in those studies, even let's just say a case series studies, if it has made an improvement to the patient's quality of life, if their face has changed, if their palate has dropped, if they are able to incorporate myofunctional therapy, breathe through their nose, and their sleep test results come back astounding, I'm sorry, but for that patient, it meant the world, and I think we can't just say, oh, well, just because there's not enough evidence-based analysis, we can just say, well, then we don't even want to consider that option. No, this is not really doing, we have a Hippocratic oath. I really believe that when we became healthcare providers, all of us swore to do no harm, but also to always do our best for our patients. We have to go to bed at night knowing we've tried everything we can. And sometimes you're the last resort. If they're, Cpap intolerant, if they will not wear that machine, like most people have a compliance issue with that, you as a dentist may be their last hope. And why would you just say, well, I don't see enough, this or that? No, I think, be that person, that lifesaver or that life extender or that lifespan and, improver that you can be as a dentist. And I'll tell you, it's just that the rewards are priceless with that. So keep in mind that even the best CPAP studies are level 4, and that there's, tracheostomy, there's level 2 evidence, but of course, more studies are needed always, but just don't dismiss a modality or choice based on the lack of. So earlier, I kind of alluded to these things it's the same slide that I kind of from the childbirth, if there is a C-section to the breastfeeding, all that, it's very, very important. Of course, I mean, if you think about processed foods, right? I want to say kind of it's a joke, but it really did happen. I think about 6 years ago, the McDonald's in Alaska put on radio commercials, and it went something like, ba-da-ba-ba-ba, we now use real chicken in our chicken McNuggets. And I'm thinking, oh my God, like what? So if you're using what kind of meat and all the preservatives? I mean, you can have like a cheeseburger sometimes from McDonald's, and it can sit out in the lawn for several like months, and it won't grow mold. So you have to think about, if we're putting that in our bodies, well, yeah, of course our body's going to create some inflammatory or allergies or compensation, things. And in the office, of course, we have to assess all the red flags, and tongue tie is one of them, and cot loads, there's measurements. So anything greater than 16 millimeters is, of course, within normal limits. But there's also different, there's lateral tongue tie, and then also all sorts of different processes and procedures. There's also that deep fascial front line, the deep front line. Sometimes when you have tongue release, patients will feel incredible, like they'll have tingling in their feet. That's another thing that shows that our whole body is interconnected. But in order to do proper myofunctional therapy, yes, tongue tie release, ankylossia treatment, whether it's lasers or the traditional scalpel methods, those should be considered, right? Okay, so moving on, there's also the range of motion. You can have to spot the cave to look at how much of tongue tie and ascertain what we need to do in order to get that tongue to be free. And doing myofunctional therapy exercises, you do need to have those tongue to be able to do that. There's some videos that Audrey Yoon and a couple of people put out for free. There's also, for example, if you're into one modality like Vivos, they actually have myofunctional therapists part of their program that you can sign up for, and we'll get into a little bit of that as we get to the different options. So this is really Zagi, and looking at so much studies and different evidence-based answers, that when you do myofunctional therapy with anything, right, with Vivos or with orthotropics or with tongue release, you're seeing much farther long-term success versus just doing the procedure. So oftentimes people say, well, I got my tongue tie released, but things relapsed or things didn't really improve. Well, it's because myofunctional therapy was not part of that. So when you combine that, it really, it's a whole lifestyle, a whole, if you will, change of development growth. And so it's very, very important. And those exercises are really, really easy. I mean, getting your obliquus oris muscle to be strong with a button, or to make that click noise, or just taking chewing gum, for example, putting in and pressing it up against your palate and then taking it out. It shows the indentation of the rugae raphe. That exercise can be done several times, and those are really, really good to help with myofunctional therapy. So, again, this is sort of a no-brainer. All of us agree that when we look at airway, just right off the bat, we need the board-certified CPMD to make the diagnosis. But also, we need to get the pediatrician involved, as well as potential, if there are teenagers or whatnot, if they have side bends, cranial strains, those issues that are kind of needing perhaps a little bit of chirodontics, which is, chiropractor / orthodontic combined, or Rockabato physical therapy, or Atlas orthogonist. Those type of things are very, very important. Some of the modalities actually would, because you're in front of a symmetrograph to turn in those cases, and you can identify those unevenness, they would actually recommend that you have the patient go to one of these interdisciplinary specialists, have the patient adjusted, and then when you adjust your appliance, you're doing it at a level, even ground. So that's very, very important for that to be part of the protocol as well. So think about in Alaska, it's trickier. We don't have as many of these specialists around, but in the continental U.S., like in Dallas, where Dr. Sania is at, they're plentiful to choose from and help out with. And realize that for children, because they're growing in development, not unlike adults where you can use a mandibular repositioning device, you can use oroplasty therapy, we are in a dynamic modality here, because the patients mixed dentition, they're growing. So all the choices, you can't just put a MRD in and expect that would do any good, because as soon as the patient grows or teeth come out, exfoliate, whatnot, you can see that appliance would not fit anymore. So, sorry, very sensitive here. Some of the very younger, as young as like 2.5, 3 years old. So I started my child at 3 with a Vivo starter. Yeah, my youngest, Warren, he gasped for air. he mouth breathed, and he had those things were just big red flags. And with these, you just have to keep in mind that you don't have to have such a demand for super compliance. And if you talk to the gurus, whether you talk to Dr. Steve Galella or Dr. Dave Singh, they'll say that when you use these and they're using them just for a couple hours at night and they spit it out, hey, that's great. With children, you have to have positive reinforcement. Again, with the food and nutrition, you have full control over. But wearing these appliances, don't think that you've done anything of a failure or a bad conclusion if they don't wear it for the full night of sleep. So this combined with myofunctional therapy is a very, very wonderful option. So Vivos, MyoBrace, Healthy Start. Now, each of them, they're pretty similar. The one thing I know, when I did ortho chain, sometimes they'll have those cleats that you have to burn into them. They could be a little tricky if the teeth are really crowded, but some people love that and enjoy that. And I'm not trying to bias anyone. I would love people to just, do some of their own research, look into the different companies, and think about some webinars and things like that. But it really, really is effective. And just keep in mind, the earlier you start. I mean, I'm serious. Sometimes you start these appliances, and like the bedwetting, the nocturia, after 2 or 3 weeks, or sometimes even sooner, the whole thing will resolve. And you're like, your patients, the parents are like, oh my gosh, you're so incredible. And you're like, all I did was just, give some myofunctional therapy recommendations and this appliance to wear. And it made the world of difference, right? So really, and having that come back, it's priceless. It's beyond any smile makeover or big implant case I've done, I'll tell you. I mean, those are changing lives and great feeling too, but making a child do better at school, or, taking them off of Ritalin or Adderall and getting their sleep right, gosh, that is just priceless. So we can go to one option that is like for teenagers. This is the Vivos DNA. This is craniofacial epigenetic pneumopedic modality. And there's also the Homeo Black, that's kind of, same type of thing, and bionators, things like that. But this is biomimetic, because when you do the protocol and you do the protocol right, you actually turn the 3-way barrel. You can do a wireframe, or you can do an acrylic. And I always do the acrylic because I'm not too big at wire bending. I'm not too big, enjoy ortho wire bending type stuff. So I use the 3-way barrel acrylic. It's a Y split, and the bottom is in the front anterior. And the mandible always follows the maxilla. But as you see the maxilla drop, for example, a very highly narrow constricted palatal arch, and you're getting that expanded. You're expanding, first of all, and a concentric expansion using this modality. A lot of the orthodontic, like Hyraxes, the rapid palate expanding, they expand transversely, which is good and great, but you have to consider the whole entire palate, anterior, posterior, as well as laterally, all need to expand. We need to really grow that and let that palate drop, right? And so oftentimes when I do a DNA, we say, well, we'll do a turn every other week, or ascertain what is. And sometimes maybe during the first couple of weeks or whatnot, you would see a palatal expansion, you'll see that white split. But then maybe the 3rd or 4th week, you're like, it's really painful. And that's actually the body saying, hey, you know what? Everybody is different. Every growth, every rate is different. So we need to respect each person's, their own individual rate of change. Anytime you violate that, and you can, because you can add more forces to orthotropics and those options, but you're risking several things. You're risking, I'm not saying it happens every time, all the time, but you're risking more inflammation. You're risking the higher degree of relapse. You're risking dehiscence, bone loss. You also, if you move teeth too quickly and you don't, have certain things bonded correctly, you may tip teeth instead of actually having a real true bone expansion type thing. So those are things to kind of keep in mind. Again, I'm not influencing anyone. I just want to give these different options so people can kind of think and discuss with their patients what is the best modality. Because with DNA, because it's biomimetic, because it's slow, it's generally sometimes 1.5 years to 2 years. If a patient is a non-compliant patient, or a patient that just wants things done right away, this may not be the best, thing, because if they spend all the time and money to do the diagnostics and they're not wearing this, and they're not, month 6, understanding that, hey, this may take 18 months, and they start, being kind of, halfway about it, what a waste of everybody's time, right? So that's something really good to consider. But when you are having a patient who's compliant, and I'll tell you, these successful DNA cases, they're just amazing. You look at the intaglio surface of the DNA and you adjust it to where the palate drops with it. You use the acrylic portion to upright the lower molars. The axial springs, believe it or not, when they have it in, when they talk, they actually vibrate. They signal the PDL space, the stem cells. And then, of course, you're thinking about osteoclastic, osteoblastic activity, and you're actually increasing the palate with this DNA appliance. It's just amazing. The next one would be with the Facial Beauty Institute. The AGGA is more LVI style, but it's all with Dr. Steve Galella. That's his appliance, his protocol. And he rather calls it, when I spoke to him last, is FORA, Fixed Osteo Remodeling Appliance, or RORA, Removable for Children and for Pediatrics. And so this is very, very interesting because it is faster, generally 4 months or so, give or take, sometimes 3 months, sometimes 5, 6 months, but you're able to create massive growth. And the growth that you get using a FAGGA or FRA is generally between the cuspid and the first bicuspid on the upper. And again, of course, the mandible follows in growth as well. But where I'm trying to say is that bone that is grown is actually good, solid radicular bone. It's solid enough that you can actually place an implant. So imagine like orthoserial extractions with distalization, really killing the airway. You can actually recapture that bicuspid space by using this appliance. You can get that really and put an implant there, or you finish with controlled arch ortho, of course. But it's a very, very neat modality. It is faster, and when it's fixed, guess what? You don't have to worry about compliance. It's already fixed inside and they just, come in and you'll have to use the lock springs and reactivate them, and then you'll find that growth, and then you'll use controlled arch ortho. Both the Vivos and this part of expansion, remember, it's kind of done in phases, right? When you expand the palate, when you get the airway right, of course, that's the most important. However, the case is not finished because, sometimes there's going to be diastema or spaces between teeth. Sometimes there are teeth that still may be rotated. Well, then you would, of course, use whether it's Invisalign or controlled arch ortho or straight wire, whatever it is, you have to consider that. But sometimes people, I'll tell you, plenty of patients, they're not very vain. They're like, okay, I just want to live a better quality of life. I want to breathe better. I don't want to have sleep apnea. And so those are things that, just to consider. For the RAGGA for children, what's really cool is there's a system set up and you follow it one by one by one. It's such a huge success. And I have them keep a little journal and I give them stickers. And so, when the appliance needs to be turned or they come in for their next visit, Dr. Gula, he's so generous. He says, sometimes you can just give them $5. I'm like, no, I'm just going to give them a toy box. I have a toy treasure chest thing in my office, and you just give them that. And, it's just amazing. It's like you'll find that the patients themselves, they're growing, they're being intrigued with that, and they can see their life is improved. And that bond and that connection is just so special. So, and the whole thing is you really don't, I don't understand people, they don't sometimes enjoy pediatric dentistry. You have to, there's, behavior, you have to pick up an anesthetic syringe, or there's tell shall do, or there's crying. But this is, no, this is appliance and getting to become a good buddy or a friend to the patient and really make their growth and development improved. It's just amazing. I don't know what else to say about that. And then there's, of course, there's no MRDs. There's oxygen gauge where you do Invisalign, and Invisalign has kind of come a long ways. Align Tech has options now to, but then I would definitely have Echovision, pharyngometry, have pulse ox to see where you're going is really going the right way. Of course, myofunctional therapy is very, very important for that as well. I'm sorry. Okay, I'm good. This is very sensitive, so I apologize. It's going backwards. Okay, there's of course Dr. Nordstrom, a very awesome alpha appliance. The adjustment for me is a little bit trickier on these, but these are also very, very light wire. And again, anytime when you look at lighter forces, especially DNA, the lightest, you're looking at much more control, a lot less inflammation, side effects, and those types of things. And then of course there's Bob Walker. I think this guy is a genius. It's very, very incredible because what we're trained and told in dental school, I was just really shocked because he actually did manual in front of me. There was dentists that attended, and he would have them stand in front of a table and in front of a symmetrograph. We would identify all the different strains and the torque, the side bends and whatnot. And he would literally manually, like, oh my gosh, right, move and manipulate the maxilla and change where everything is level. And the person getting that done would say, oh my gosh, I feel euphoric right now. Like, this is incredible. Wow, my bite's even and things like that. And he has a rule now. Bob Walker says, I will not train any chiropractor unless they bring a dentist with him or her. And the reason why is after a couple of hours of swallowing and functioning, all the adjustments all collapse. So a dentist with a pad or a dentist with what we are able to do can maintain that. And this is why when we connect things with the DNA or the orthotropics or other options, it's important to do interdisciplinary, because when you level things off, oh my gosh, you're looking at the occiput and you're looking at all these different things. And there may be, trauma, fell off a bike, car accident, the whole slew of things that can contribute to that, or just body compensation because of airway issues and diet, nutrition, things like that. But this is important to kind of consider all of that, the torticollis, all those things that can. And then, of course, there is plenty of evidence based on the traditional Hyrax, palatal expansion, things like that. But just know that when you're doing a lot of forces, this is a transverse expansion. Think about other modalities, maybe that after you expand, you still need some Invisalign or whatnot to make a concentric overall. But the more quickly you do it, then again, inflammation, relapse, those type of things, just kind of keep in mind. Okay, and the overall AHI direction, 70% on the literature that shows. So it's a very, very thing to consider. So again, I want to say that all these different options, compliance is very much key when it's removable. When things are fixed, then, but of course, the fixed appliance, for example, the Facial Bead Institute, you have to have you can't be in mixed dentition. Actually, you can, like towards the latter part. So you're looking at maybe 11 years old or so, but removable, it gives you a chance to bond with the patient, bond with the parents, have these diaries and journals and stickers and prizes, and they're growing, they're behaving a lot better at school. They're able to do sports, and I'm telling you, it's just so rewarding, and you're able to affect the child's growth with that. And again, I was sorry. A reminder of using equipment. Echovision is one of them, cone beam. Those can gauge the progress. Finishing the cases with braces and ortho, just like any orthodontic cases. Make sure you take photos as you would with any ortho cases. And this is really cute. I wish the video, we tried to download the video, but it would not work. If you guys want a link, later you can email to my office supervisor, Dr. Will Kurst. He can give that. But this little girl, I can just kind of show you, she had all the signs and symptoms. Her mom's a special ed teacher for head posture, mouth breathing, a deep overbite. You can see that. We scanned her teeth and we did a Vivo system. So this has been where the video would have been. But I can tell you, it's so incredible. Her story is just, she would always wake her sisters up. She'd be so, irritable. Sometimes she'd have a good day, it'll be okay. And the next minute you'd tell her to take the trash out. She would throw a temper tantrum. And just night and day. So her mom at the end of the video says, why don't you ask Scarlett what she wants to be when she grows up? And so I said, oh, okay. So after that, and we cut it on the video recording, and she says, I want to be a dentist. So I was like, oh my God, yay. And so those things that you're able to do, and affect the child's airway. And the mom, being a special ed teacher, she sees a lot of kids with behavioral, with airway issues, and it's such an awareness thing that's not out there. So I beseech, I beg, I implore the people on this webinar, dentists throughout the world, when they look at pediatric airway, we as dentists, yes, we have an effective way of treatment that can really change the life of the child. And so thank you all for you paying attention. I'm leaving some time for some questions. And Dr. Sonia, I hope everything was clear. Everyone was able to hear everything, I hope, right? And I think you're on mute still or whatnot. Let's see.
Yes.
Here. Okay, now you're
back.
okay. Okay.
So I think you can stop sharing the screen.
Okay, let me go stop share right there. Okay. All right.
Thank you. That was a
You're
wonderful
welcome.
presentation.
Oh, thank you.
So enlightening. I'm sure people were watching and like just wondering why I'm not doing this yet. Just
Yeah.
we have to stop thinking about, I keep saying this, stop thinking about just treating teeth, right? Teeth is the last
Yes.
thing we look
Yes.
in a health, for a health person.
Yeah.
So it seems like we are walking towards more wellness dentistry, as I want to
Yes.
call it.
Yes.
Correct? Um, yeah, so tell me a bit about your experience with the behavior aspect of this, because we haven't been noticing that when we treat airway, we also do some airway with Vivos and other appliances here. We
Hmm.
started noticing that the children do change behavior, and we see there are some things in the literature too showing that. Now, what's your personal experience,
I
like
want to
with
share two
anxiety,
examples.
especially, and even I've seen some case that, I mean, I don't know because kind of not very well researched this aspect yet, I don't think,
Yeah,
but like shyness, I've seen
yeah,
some things that
yeah.
even there. So can you comment on this for me because
Yeah.
it's so
I'll,
fascinating?
I'll share, and when I was at the Vivos giving a presentation, I'll share one of the most emotional, touching kids. So by the time he seen me, he was already 16 years old. And this kid, and talk about behavior and talk about what he went through, it is so emotional because he had a tick. So when he talked, his face would be like really, he'd be like this, and he'll shake. And I did Vivos on it, did a DNA appliance, and I thought, okay, I'm just gonna do your airway. I'm gonna just hopefully. And I'm not qualified to treat tick facialis, and I'm just a dentist, right? And so
Right,
what was incredible was after maybe even 2 or 3 weeks, you would see because some of his ticks were so his head would be it's almost like Tourette slash. And I went to Dr. Singh. I said, oh my gosh, it's like I had no idea that his tick would actually literally it's not 100% gone, but I would say over 60%. And he says, he almost was in tears. He says, Dr. Who, first of all, when my mom took me to pediatrician, they told me that I would grow out of it. They said that I'll just one day become a-okay. And I'm 16 years old. I never grew out of it. And at school, I have no friends. I have, my teacher, when I talk, they laugh at me, and and I'm just like, oh my God, your heart just breaks, right? Because this is something, in your back of your mind thinking, okay, I'm a dentist, and this is a big thing. This is out of my, but Dr. Singh says, hey, look, if you think about tick, right? You think about the nervous system, you think about sympathetic overload, you think about compensation, you think about cortisol, cytokines, and your nerves and everything is just going too much. Some people may react this way, so other people, well, for this person, this child, this teenager, unfortunately, it was a tick issue. And so when you're able to apply myofunctional therapy, able to expand the palate, able to change diet and nutrition, holy cow, right? Like Dr. Stein, it's like his ticks, and he's talking, he goes, oh my God, and he's just, now I'm losing weight and all these things, and you're thinking, I'm just a dentist and I'm able to do that.
yes,
So I really want, and I know you really want people to understand what literally it's a calling for us. We as dentists can make
yes.
the life change, behavioral change so much. Another thing too is my own child. I am going to take my kid actually next week to the Amen clinic. So they're going to do a brain scan because he was a premature baby, and we put him through Vivos. He's doing much better, but there's still certain things too, like the shyness and whatnot. But I'm telling you, sports, communication, being alert, that's all part of it. How can you expect a child to be at school and be friends when they're tired all the time? And if they're doing sports and they want to be not the last one picked when they divide into teams, well, they got to be awake. They got to be, you know what I mean?
Right.
So yes, we as teeth doctors go beyond the teeth, go for wellness. It's the most important thing I can say.
Yes, I love that. I work here with one of the doctors in Dallas, and we set up like a program that we together when we set up the treatment plan, and we incorporate, okay, for your case, you're going to have to do myofunctional therapy, tongue tie release, let's say, and chiropractic to correct the compensation. And what we decide is like, okay, if you think this is important for them, this is how we do it. If you're willing to do this, we'll take it. If not, we're not going to do half-heartedly, because
That's right. That's right.
we want to work with you and give you back to, like a new breath of life, right?
Yes, yes, yes.
So we did that, and we actually are even thinking about the whole package in a way that they don't think, oh, but this is going to be, having to pay extra for this. So we're kind of trying to even wrap it up. So it's like, okay, here's the package. Let us look after you, and we're bringing professionals to the places, so don't have to
Yes.
go traveling around. We coordinate everything from our center. And okay, now it's time to go to the ENT. Now we want to, so it is very nice, but it's so
Yeah.
beautiful when you see the result, like you say.
Yes, yes.
Yeah.
And then the thing is, I think that if we even just make, in our lifetime, 10 or so people, and we can make that kind of difference, I am so thankful and grateful that, if you're spiritual, I thank God. If you're not, just thank nature that you're given that ability to do that for people. Because I think this is why we all became healthcare professionals. We want to make a difference
Yes.
and make them people have a better quality of life. And wow, right? And so it's such a double rewarding thing. I often feel like, every time when you treat these patients, you're actually making yourself happier. I mean, I gain more from that, right? From doing those
That's
things.
true. Yes, that's true.
So yeah.
That's the
Well,
satisfaction also, is
yeah.
for us. So when you talked about, can you talk a bit more about how do you incorporate, or how is your system regarding the chiropractic in your clinic?
So
How
yeah,
do, yeah.
yeah. Well, we always, so my practice, always the kids come naturally because like the American Dental Association said in 2000, I think 17, they had not a mandate, but a recommendation that every dentist needs to screen for airway.
Yes.
Everyone walks you cannot judge a book by its cover, right? So when we get that conversation going, I'll have my auxiliary, and I'm going to be truthful about this, right? If you want to get into this, it is so important to get your team members involved because why? There's some weird psychology in this because anytime, even if I mean it from the heart, the patient will think, well, you're still the business owner, you're still the dentist, so there's some kind of money thing behind it. So I'm like, okay, but when my assistant or my hygienist or my front desk is this passionate the way that I am, and they're sitting like, like, oh my gosh, I mean, I look at your systemic history, you're on this medication, that medication, you have high blood pressure, da da da. And then pretty soon they say, hey, by the way, does your kid snore too? And things like that. So it naturally develops into the entire family, right? But where I was getting at is it's so critical to get your team members trained, involved in this, because oftentimes when you start some of these modalities, they themselves, with their own family, their own kids, their own husband or wife, whatever, will have airway issues, and then you can kind of start by that, and then eventually they experience it, you experience it. It's so organic, right? And that's how it really. I'm telling you, Dr. Sonia, and I know you're aware, there are plenty of dentists, especially during retirement, where they're like, what do I do? Or I really don't want to. I'm telling you, dental sleep medicine is such a wonderful blessing. We were talking earlier about cosmetic dentistry shifted into implant dentistry, and the future really is dental sleep medicine. And I don't care if you're talking about sleep bruxism and all those things tied to our restorative work and stuff like that. Absolutely, it's important to realize that airway is tied to everything, but it's such a possible, not I don't want to say lucrative, but possible production wise thing that you can do. And if you're just doing, for example, MRDs, you don't even need to pick up a handpiece. You can have a limited two operatory, like 2-3 employee type of thing, and run a very, very successful
Yes.
dental sleep medicine practice. You know what I mean? So, and then once again, okay, we kind of ADA, American Dental Association, says we need to, but really for our Hippocratic oath, we really can't no longer just say, well, we're just gonna come and do a quick, 2-minute exam and then, get your cleaning done and get a couple of filling schedule. No, we have to look beyond the teeth. We got to look at airway, malempati, retrognathia, all those things, and make a difference, right? And because if a patient sleep bruxes at night trying to fight for pain airway, believe me, there's pitch, roll, yaw, anterior, posterior, lateral, vertical, all these different things going on. It's not just the border movements that we check in a person's bite, but all those things that occur. So anyway.
Yes, and I think in our post-COVID, people are kind of trying to look for something with less aerosol and kind of
Yes, right?
more. So
Exactly.
it is a huge,
Demonstrate medicine, that's it. Yeah, yeah.
yes. So probably
So,
be some people be they say retiring their drill and looking for other alternatives. Now,
yeah,
how do you find? I mean, here in the because still sleep medicine is that's a good time actually for dentists to join the
right.
train because I mean the train's kind of starting. It's not really gone full way because it's such a epidemic
Yeah,
with
sure
the
is.
small growth of the maxillary with our Western habits.
Yes.
But we still find, I think one of the barriers we find with the patients is that, of course, they still need it. We're having to educate them. Sometimes they come
Yeah.
on, have bruxism or whatever. You say, oh, okay, you have all this, which is fine because we can explain this very well. But then many times the barrier is like insurance. Does it take insurance? Because it's not a very, I mean, relatively, it's not a $1,000 treatment because we stay
That's
with this
right.
patient for a while. And with all this
Yes.
system that we treat, and is the myofunctional and it's tongue release or whatever. How do you find that this insurance is kind of
So, yeah.
really
So if you,
blocking many patients from being
yeah. Well,
healthy?
there's two things. Actually, there's three things. You have to look at how much you want to dive into the world of dental sleep medicine. If you want to do MRDs and orthotropics, there's so many different organizations like Vivos. See, Vivos is actually traded on Nasdaq. They're a public IPO company, right? And
Yes.
in their system, they actually have medical billing for you. There's a lot, even with Cpap Solutions or with other, they have Brady billing and things like that because remember, this is a medical condition, so it's a whole different
Mm.
animal than dental insurance. And so with medical insurance, there's a lot of good things about it, and there's a lot of very important things that we need to know about, but there's also some challenges and things like that, that especially when I would think that you're starting out brand new, having someone hold your hand like Brady Billing or like the Vivos billing system is very, very important. But eventually, if you have a very, very energetic, like my Dr. Will Kirst, he's a neurologist. He loves billing. He knows left and right. He's my computer IT guy. Earlier this morning, he's a lifesaver, right? But you can find internally. But right off the bat, I would definitely rely on a company. Generally, they just have, take 10%, sometimes 12% of whatever they collect. But that's very important. The trick is this, okay? And I want people to remember this. And we do, as dentists, we punish ourselves way too much, okay? So I think, okay, first of all, dental insurance really to me is not insurance. It's more like a gift certificate, okay? Because insurance is defined as something that's helping you catastrophically. So if your home burned down and you have a home insurance, yes, that's, or if you have medical insurance, you have a $1 million surgery, yes, that's really insurance, not a $1,500, $2,000 cap per year type of thing. It's just a joke. It's like a gift certificate, right? But with
Yes.
medical insurance, because you don't have that gap, once you meet your deductible, the sky's the limit. So that's one thing. But also remember this, right? What do we do as a dentist? Well, I want to give an analogy of my mother, who is now on dialysis. Her kidney has failed. Okay. And so over 4 decades, she had hypertension and she took multiple medications for that. Okay. And then her kidneys can't handle it and her kidneys failed. But with that, they never asked her once if she snored or gasped for air at night. None of her primary care physicians or internal medicine ever asked for that. Okay. Now get that even more further. She one time took a blood pressure medication that caused her to have a weird side effect. She started growing facial hair. And so she went to see the doctor. She waited 2 hours, literally 2 hours in the waiting room. Then another 15 minutes, the nurse comes and gets her, weighs her, takes her blood pressure. The doctor comes in, okay, says, "Hi, Celia, so I hear this gives you a weird side effect." Okay, 2 seconds, writes a prescription, leaves the room. She goes out with a $350 bill. So I want to tell you that whole analogy. Was it my mom's fault that she was allergic to that medication? No. Was it like her fault that she waited 2 hours? No. And she still got stuck with $350, right, of a bill.
Mm-hmm.
Contrast that to the dentist. Now, I know for all of us who's practiced for years, when we numb up the patients, sometimes their occlusion isn't exactly the same as they become unnumb. So when you do a filling, and you checked all the excursions, you checked microocclusion, you checked for class 1 through 3 interferences, you checked for all of that, everything looks fine. And then a day or two later, the patient comes back and says, "Oh, I think the filling is high or something's high." What do? We have the patient come back in free this, free that, free OSHA, free my payroll, free my utilities, free everything, and it's expected. And imagine, contrast that with the medical doctor situation, right? With my mother. I mean,
Yes.
really, our medical model is not right. And we as dentists, we're meticulous. If we have a 1 millimeter, half a millimeter thing, we lose sleep over it, right? We're that, particular in what we do. So I have to say, really, when we jump into dental sleep medicine, it's a medical condition. And I'm sorry, when they're coming in for an adjustment, when they're coming in for a Vivos adjustment or RIGG, and when I talk about stickers, guess what? My time is valuable. Guess what? I have a business to run. I have bills to pay, right? So we have to not forget that aspect. And remember, having a billing company help you along in the beginning will be very, very important. Later, if you have someone that you find in your office who's very passionate and wants to help you bill, absolutely.
Okay, so you think that dentists could work with the billing system for the medical? Of course, the dental is like pathetic, right?
Well,
Okay.
I actually am working today, so I think, is it about
Yeah.
time? Because I know we started
Yes, we
late,
are
but thank you very
finishing
much.
off. I was just going to thank you very much. It was such a wonderful presentation.
Thank
And
you.
I'm very happy that you are making a difference
Oh,
in the
thank you
life
so
of
much, Dr.
these
Sunny. Same
people
with
and these
you.
students.
It's a pleasure for all of this, and I just hope that we can inspire more people to do that.
Yes.
And thank you all for having me be one of the 100 top doctors. That's a nice honor. I appreciate it, and I hope people do dental sleep medicine.
Thank you very much. Thank you all for watching. Thank you.